1, 2, 3, 4, 5, 6. Testing, mic check. This is from the interpreter, 1, 2, 3, 4, 5, 6. Mic check. This is from the translator, 1, 2, 3, 4, 5, 6. This is the English channel, signing on, testing, 1, 2, 3, 4, 5, 6. Testing, mic check. Make sure you can hear the voice of the interpreter counting on the English channel right now. 1, 2, 3, 4, 5, 6, 7, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. That's important for the Q&A session. 1, 2, 3, 4, 5, 6. This is the English channel, signing on, 1, 2, 3, 4, 5, 6. Mic check, testing, 1, 2, 3, 4, 5, 6, 7, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, 0. 1, 2, 3, 4, 5, 6, 7. If you're on the English channel right now, you should hear the voice of the interpreter counting. Just to give us a sign, you can hear us. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. This will be needed for the question and answer session. If there are any questions, they will be translated into English from Russian. Okay, thanks.
Okay, I will call Juro now to see what is going on.
Да, так, всех отлично видно, давайте мы проверим.
Они все, они кроме одного все сидят. А, нет, первого нет. Ну, в смысле, он зайдет, но уже 8 минут.
Хорошо, смотрите, у нас как получается. У нас еще президент Александр Григорьевич, он откроет, дальше передаст подходы, и потом дальше мы.
Đuro, čekamo te na Zoomu svi. Pa za 5 minuta, ajde. Ajde, važi, ciao. Here he is in a minute. Just take a connection.
Все, тогда в целом вы пока можете отключить камеру, как вы слышите, Александр Григорьевич, в целом может быть.
He believes that his technical abilities are perfect, so no need.
Как только вы заканчиваете читать протокол, сразу закрываете свой сайт, чтобы еще читать, не с большой задержкой, могут отправить свою, и на промежуточке вы довольны. Если у вас будут какие-то вопросы во время,
what do we have?
вы можете писать в чат, я буду читать.
At this moment, Juro will organize in a 2 weeks something. It's called Hybrid Congress, because a small number will participate personally, but most of the people will be using Zoom, or I don't know. I think using Zoom connection.
Great.
Oh, excellent. Yes.
Yeah.
And Jose, what do we need to enter, for example, to Lisbon? Vaccination is not enough? No. Mhm. 嗯 where? But where? In Portugal or in our country? Here is Juro. Okay.
One, two, three, four, five, six. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. This is from the interpreter, the English channel, signing on. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. If you are on the English channel, you should hear the interpreter counting right now. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. Mic check. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. Testing. Make sure you're on the English channel if you are an English speaking participant. This is from the interpreter. Testing. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. Testing. We're about to start. Thank you.
Jura, please share your presentation. Просто рус интерпретер Елена. The operator will announce that we are beginning. I ask everybody except Jura to switch off your mix.
Please, those who do not make the presentation, switch off your mics. And vice versa, when you speak, do not forget to turn them on. Thank you. Once again, this is from the interpreter testing the English channel 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6, 7. This is the English channel signing on 1, 2, 3, 4, 5, 6. Mic check. Make sure you're on the English channel. That will be needed for the Q&A session later if there are any questions. Thank you.
Good morning, everyone. I think we can.
Доброе утро, дорогие участники. Добрый день.
I think we can
Я
start
думаю,
our
мы
symposium
можем
now.
начинать наш сателлитный симпозиум.
I will give a word now to Professor
Я
Mats
скажу
to open our
сейчас
symposium.
несколько слов. Это зал номер 6. Последние тенденции в вопросах нарушения метаболизма и репродуктивной эндокринологии. Слово предоставляется нашему первому докладчику Дюро Макуту. Пожалуйста, Дюро, вы можете начинать.
Thank you very much, Goran. I'm really very happy that we are again with you and that we are together on the 12th Congress of the Eurasian Association of Therapists, and that we are organizing again the Endocrine Symposium. This year we will remain on the south of Europe, and it is really a great pleasure to have fantastic 4 speakers today with us, and that we will share with you our experience from the field of endocrinology. Goran, please.
Okay. Juro, please, can you tell us what is the new in gestational diabetes? Tell us about something about endocrine approach. Juro, the Zoom is yours.
Thank you, Goran. So let's talk about and let's just remain what are the key points and what are the new developments in the area of the true clinical issue that is the gestational diabetes. So if we are talking about the diagnosis, it is diagnosed during pregnancy, and it's not clearly over diabetes, only in a case that we do not have already the diabetic patient that it is in front of us. So the adverse pregnancy outcomes are fetal macrosomia, stillbirth, or another metabolic disturbances that are quite important and we have to follow and to know. And those women are with increased risk for prenatal morbidity and type 2 diabetes after the pregnancy. So that's why it's quite important to follow these patients for a long period, not during the pregnancy, but also to the rest of their lives. The prevalence is very varying. So we have the quite low numbers in the north of Europe, which is increasing to almost 10 times to the south of Europe. So you see between 0.6 and 6.3% of the prevalence. There are some analyses from the United States that say that about 7% of all pregnancies within the United States are complicated by the gestational diabetes, meaning that they have about 200,000 cases annually. So if we use the new criteria introduced by the International Association of Diabetes in Pregnancy Study Group, we are even climbing to the fascinating number of even 26% of the hyperglycemic women that are going into the diabetes. So this is a new era with the recognizing even the not so overt types of deterioration of the glucose metabolism with those ladies. Another very important issue is the prevalence of gestational diabetes related to the income of the country. So you can see on the left side of this slide that the countries with a lower income are actually much more prevalent with the gestational diabetes, coming to the almost 25%. While in the area where we are belonging, the prevalence is quite lower, and this is really in the direct correlation with the income. So this is something really very important to have and to have on our minds. What is the general etiopathogenesis of the gestational diabetes? And in the first place is the adiposity, which is the most and the very important factor for the development of gestational diabetes, and the influences that are evolved from the diabetes, from the obesity. So the gestational diabetes is developed when the pancreatic beta cells of those women are unable to increase the production to cover the needs for the load of the glucose that is all around. If we just take a look in this very busy slide, you can see that there are many receptors and many post-receptors mechanisms that are leading toward the nucleus of every cell of those ladies, and that are really mediated by the GLUT transporters that are not very well functioning in some cases. So besides the insulin receptors, we have other ones that are quite much influencing, like the TNF-alpha, interleukin-6, or leptin and adiponectin, which are acting over the AMPK kinase, so that they could influence the different mediating processes in the genomic transferring of the information coming from the receptors to the cells. If we are talking about the diagnosis, if we use the International Association of Diabetes and Pregnancy Study group criteria, which are changing the whole spectrum or increasing the prevalence, we can see that with those criteria, we need to have only one criteria of elevation. So we have to have either increased fasting glucose over 5.1 millimoles per liter, or the first hour over 10 millimoles, or the second hour over 8.5. And this is the first slide or the first information to keep on our minds, that we have to address only three numbers in every OGTT that we are performing in our pregnant ladies suspected to have the gestational diabetes. But before the further follow-up with them, we have to screen the complications. And this is very important with those that are already with overt diabetes, not to have the situation to progress with the complication. That's why we have to screen for the retinopathy. That's why we need the ophthalmologist, but also the nephropathy to assess the filtration of the kidney. What is important to know about the preconception goals for the monitoring of the further follow-up of the diabetes with those ladies? So preconceptional glucose needs to be in the meaning of the HbA1c, according to the two American societies, below 6.5 or 7%. So these are the goals that we have to achieve before pregnancies in ladies that are with the glucose tolerance problems. What are the potential effects on those glycoregulation within the embryos or the fetuses? So this is one of the questions that is very subtle, often asked, but we have to know that we have two phases. We have the early post-implantation embryo cells, and we have the differentiated or placental embryonic cells. In the first class of the cells, we actually do not have any influence of the glucose in the meaning of the controlled by the use of metformin. So we do not have the effect of any drugs, because the majority of the most of the glucose volume is going into the lactates. So metformin is not sensitive in those cells. Cells are not sensitive to the therapies with metformin, in comparison to the placental embryonic stem cells that are sensitive to the therapies, because the mitochondrial content is quite more increased, and the glucose is with the oxidative metabolism within the cells. So the metformin intervention could be later on, and it's not affecting the embryonic phase of the life of the new baby. The famous HAPO study showed for the first time something that we were always asking about. What are the ratios, or what are the levels of glucose that could influence on something, and what are the unfavorable outcomes? So just to simplify a very specific and very in detail study, I can say that we have glucose categories on the lower line, and we have the frequency of something that we are following on the y-axis. So this is the most important maybe outcome, is that the percentile of the birth rate is in direct correlation with the glucose categories. So if we are increasing with the glucose categories on this x-axis, we can see that the birth rate is increasing, and what is the most important is that it is increasing even with the measuring of the fasting glucose. So this study is stressing on many points, and one of the most important is that even the basal glucose analysis or the fasting glucose could be a very good surrogate for the assessment of the outcome or the follow-up with those ladies. What are the benefits of treatment of gestational diabetes? If we are talking just in general, the most important ones are not to have big babies, not to have the shoulder dystocia, and not to have actually the increase of the volume of the baby through the very close monitoring by the gynecologist, with which we are really working in a very tight connection. What are the management goals in the diabetic ladies? So the first one is to educate the patient to maintain good nutrition and glucose control before conception, during pregnancy, but also after the pregnancies. So we can follow this with a close look on their biochemical analysis and to monitor the HbA1c even weekly. This is not realistic within our health surroundings or our environment, but this is one of the proposals given by the American Association of the Clinical Endocrinologists. The conclusion is that we have to monitor HbA1c together with the glucose very closely and very tightly. What are the recommendations for the treatment or the goals for the treatment? So, according to the International Association for the Diabetes in Pregnancy, it should be preprandial to be below or up to 5.3 millimoles, 1 hour postprandial glucose to be less than 7.8, and 2 hours postprandial to be less than 6.7 millimoles per liter. So this is another set of numbers that we have to keep on our mind when we are following the exact pregnant lady. How can we monitor the glucose? We can actually use the very simple self-monitoring of the blood glucose technique, I can say, which means that we should monitor or measure glucose. We should ask to the lady to monitor at least 3 times per day. So morning fasting, pre-meal, and 1 hour after the meal, and also before the bed. So this is the cornerstone of glucose management during pregnancy, and this is definitely the golden standard. That is the first one with the HbA1c that is becoming the second one. So together with the self-monitoring of blood glucose, those two parameters are really absolutely necessity for the endocrinologist to monitor the to have the safe pregnancy with the diabetic woman. Another quite useful thing is the continuous glucose monitoring, which is quite demanding and expensive at the same time, because we need to have the sensors and to have devices for the downloading the curves, and to have the specially organized team for this. But as we can notice, in the majority of the countries, we have now a reimbursement policy which is in favor of having the glucose monitors today, and this will be the future of the follow-up, not only of the glucose of the diabetic patients that are pregnant, but also of the regular follow-up of the type 1, and we hope also the type 2 diabetics. What are the pharmacological treatments of diabetes during pregnancy? The standards in Europe, I can say in Europe, are the basal insulins. So we could have the human insulin or the insulin detamir that are registered formally for a long period for this. And we could also have the prandial insulins, so the analogs which are preferred, but also the regular insulins are quite acceptable, and they are still the standard of therapy in the most of the countries worldwide. We are questioning always about the oral therapies. We have two therapies, or the two groups of the drugs medications that are approved in some parts of the world and followed in some parts of the world as well. These are the metformin and the sulfonylurea glyburil. they are differently crossing the placenta, and the classification about the safety is a little bit different. So they are still in the category B, while other sulfonylureas are even not recommended to be used within the pregnancy. Just to note that the sulfonylureas are equalized with insulin treatments in the United States, so they are not widely approved within the European continent. So what are the benefits and risks of metformin therapy? The majority of the outcomes are in favor, so we can stop the development of the pregnancy-induced hypertension or preeclampsia. And with infant, we could also expect to have less increase of the volume of the baby, so have less large for gestational age, or the different things like the clinically present, like the hypoglycemia with the infant. What about the insulin dosing? This is also the question which we have to address with our patients when they are sitting in front of us, and we can just split the phases of the insulin therapy according to the trimesters. And you can see on the lines on this table, the first 13 weeks, we can easily multiply 0.3 with the weight, in the second trimester with 0.35, in the last part with 0.4, and to adjust the doses of insulin around the delivery. After that, we can decline, we can actually adjust the therapies toward the patient needs, taking into the consideration the pre-treatment with the patient, especially if they are type 1 diabetics. What are the benefits and what are the limitations? The benefits, we can use the benefit of the continuous subcutaneous insulin infusion. So this is the device that is continuously delivering the insulin to the pregnant lady, and we can actually make physiological insulin secretion, but we have to tightly control the ladies. The limitation is the complexity, because we have to counsel and to monitor very closely those ladies, and we could actually have some problems, technical ones, with the pumps, and of course the cost. These are very costly and expensive devices, but they are approved in some of the countries and reimbursed for the type 1 diabetics to be given to them. This is one of the studies, of the very recent studies, that is the meta-analysis of the safety profiles and efficacy of metformin, glyburide, and insulin treatments. And I will just remind you on what I already said with the differences between those two. One of the most not favorable things is that this study showed that insulin is actually showing an increase in the large for gestational age babies. So we have to be very observed with the studies and also with the meta-analysis. Namely, we have to know the ladies, we have to know the origin of those. We could not mix the different locations, groups, different diagnostic criteria when we are analyzing the data, because we can come to the different type of the outcomes. So, for instance, with this study, we can see that even with insulin, we are expecting to have more big babies. The same approach will be also with macrosomia. So, just to remind you, we have to know our patients and to know how to follow them up in the close collaboration with our gynecologist. And just for the very end of this presentation, the last two slides, this is something that is now much more stressed than before. How the gestational diabetes is influencing the maternal immune dysregulation. So today we are talking about the possibility that the diabetes with the pregnant ladies is activating different things. So we have the activating of the natural killer cell cytotoxicity, monocyte activation, different macrophages, or the activation of the macrophages and infiltration of the macrophages, then deterioration of the insulin resistance and other things. That's why the research in this area is coming to the possibility to include immune regulatory drugs or compounds that could be the monoclonal antibodies, for instance, specific inhibitors, or some specific antioxidants, mitochondrial antioxidants, that could decrease the reactive oxidative species production, that could also affect the decrease of the interleukin, and in general to close, actually to decrease the activity of the inflammation with those layers. Thank you very much for this, and I would like to announce the second speaker of today, which is a very close friend of mine, Goran Cvilic from Belgrade, that will talk us about the metabolic and reproductive effects of melatonin therapy. Goran, please, floor is now yours, or the Zoom is yours now.
Thank you, Juro. First of all, I would again thanks to organizer for inviting us to be a part of your conference. This is fourth consecutive year that we are participating Eurasian conference, and I must say that I am very proud on that part of my CV. Today, I will speak about the effects of melatonin therapy on metabolic profile in patients with metabolic syndrome, as well as the effect of melatonin therapy on reproductive health in women. This is something that you all probably know. Melatonin is hormone synthesized from the serotonin, secreted mostly by a pineal gland, and its main function is to maintain circadian rhythm, actually shifting our daylight metabolism to night metabolism and opposite. As you can notice, its concentration in bloodstream starts to rise approximately at 10 p.m. The peak value is approximately at 2 in the morning, and at 6 in the morning, it falls to the daylight concentration. But this is not the only function that melatonin has in our body. It has a very, very potent antioxidative properties, and due to that, during the last 10 years, there are many cell pleiotropic effects were observed. So this scheme looks complicated, but actually it is not. Here you can see that melatonin significantly reduces chronic inflammation. It improves insulin secretion and improves insulin sensitivity at periphery and at the liver level. It improves our lipid profile. It helps us normalization of blood pressure and regression of atherosclerosis. On the other hand, it has absolutely a direct effect on the ovaries, improving quality of the oocytes. So the first part of my talk, I will speak about metabolic effects of melatonin therapy. I will start this story with these in vitro studies suggesting that treatment with melatonin will significantly reduce glucose-stimulated insulin secretion. Actually, it is helping us to maintain normal glucose values after glucose stimulation, with as small as possible insulin concentration. So actually it's improving insulin sensitivity. The first clinical study I will present is a study of the obese non-diabetic women who were treated with daily dose of 6 milligrams of melatonin. It shows us that this treatment will significantly reduce body weight and waist circumference. But as you can notice, at the same time, there was not significantly different percentage of change in comparison with placebo. But at the same time, only in women who were treated with melatonin, there was a striking reduction in chronic inflammation, a striking reduction in high sensitivity CRP, tumor necrosis factor alpha, and interleukin 6. So this effect was unique only to melatonin therapy. In comparison to that, women treated with placebo does not notice any change in this direction. Furthermore, this is a study on obese people who had extreme insulin resistant with a skin marker with acanthosis nigricans. And here you can see that their basal insulin and stimulated insulin levels were extremely high during OGDT. For those who are not maybe so familiar with this, normal fasting insulin levels are less than 10, and they should not exceed over 100 after stimulation. After treatment with melatonin, you can see how all these levels are reduced, and the indices of insulin sensitivity, HOMA and Matsuda index, were significantly improved after melatonin treatment. And those people are extremely insulin resistant, and this improvement was observed with only 3 milligrams of melatonin per day. Again, we see significant improvement in markers of chronic inflammation, such as CRP and tumor necrosis alpha. And the third separate study I will present is a study from Poland, one of the most cited in the last years. Actually, this is a study on patients who have non-alcoholic steatohepatitis. We all know that these patients have typical biochemical, echosonographic, and clinical findings on insulin resistance, and they are very prone to develop type 2 diabetes in future. So here we notice that treatment with melatonin will significantly reduce the level of gamma GT. It will improve the triglyceride levels. It will improve the LDL cholesterol. At the same time, there was, again, a significant reduction in markers of chronic inflammation, interleukins 1 and 6, and tumor necrosis factor alpha. But the most striking result of this study is actually pathogistological finding of the livers. This study was designed that all the patients with NASH had liver biopsy before and after treatment with melatonin. So I will show you the picture of one patient. Here you can notice how much this pathogistological finding is improved. You see how the significant reduction in the frequency and in the volume of the lipid droplets in the liver. There are many studies with a similar design, so I will now speak about meta-analysis, and this is one of them that all of them are showing us the significant reduction of LDL cholesterol after melatonin treatment. Of course, it is observed if that treatment lasts for at least 8 weeks, but it is normal because every treatment for lipids, when we want to make evaluation, should last at least 8 weeks. HDL cholesterol was improved, but it does not reach the level of statistical significance. And the level of triglyceride was statistically significantly reduced, even if the therapy lasted less than 8 weeks. At the same study, there was no significant changes in body weight. What about glucose? This meta-analysis show us that melatonin significantly reduced fasting blood glucose. It reduces also the levels of HbA1c, but the level of statistical significance in this meta-analysis was not reached. The same study evaluated the insulin sensitivity, and here it was assessed during using HOMA and Quick indices. I must say that those two indices use the same parameters, the basal glycemia and basal insulinemia, but in the case of Quickie, we use logarithm values because we want to prevent huge heterogeneity of the variables. So in that case, melatonin show significant improvement in insulin sensitivity. And What is important also, it is important that this observation was noticed independent of the dosage. Is it 3 or 10 or any other dose of the melatonin? And I must say that these doses are the small dosages. For example, for some neurological diseases, there were studies with even 300 milligrams of melatonin per day. So when we are talking about metabolic syndrome, we mentioned lipid profile, we mentioned chronic inflammation, we mentioned glycemia, unfortunately no effect on body weight, but what about hypertension? These meta-analyses are clearly showing us that melatonin treatment significantly reduce both systolic and diastolic night blood pressure. And I must now say two facts, very important. You know that patients with essential hypertension might be those with, who have a deeper and those who are non-deeper hypertension. Especially important population are those who are non-deepers because there is no circadian rhythm of hypertension, and those patients had much more they're much more prone to develop micro and macrovascular complications of hypertension, for example, such as microalbuminuria. In this subgroup of hypertension patients, you will always find this pattern of improvement. In those patients who are deepers, this finding might not be so uniform because it might be that you will not see the effect of melatonin treatment as it is in the previous group. Second thing, all the doctors who treat patients with hypertension frequently hear that that patients who are using beta blockers usually have insomnia as adverse event. So I can tell you that, and the studies show that this adverse event can be easily prevented with treatment with melatonin. So if we analyze all the previous results, we can see that melatonin is a very nice treatment for reduction of cardiovascular risk factors, except reduction in body weight. At least studies did not confirm that. And here is one nice scheme showing us that the treatment with melatonin using its potent antioxidant and anti-inflammatory and the other effects could reduce the risk for cardiomyopathy, for heart failure, and ischemic heart diseases. But all these speculations are actually made from the studies on the animals and in vitro studies. There are a very small number of studies in humans. And we are witnesses that many times those results on those type of the study were not translated in a real world life actually, or in clinical studies with humans. And in this particular case, I can confirm that it is the same situation with myocardial ischemia reperfusion injury, because there are two really good studies that were the subject with acute STEMI, the ST elevation myocardial infarction, were evaluated, and during primary PCI, intracoronary and intravenous melatonin infusion was done. So what is the result? The result was disappointing because there was no improvement in ejection fraction and in the left ventricle volume, or there was no improvement in area of the infarction. It was not smaller in comparison to the placebo. So definitely metformin treatment is a treatment for primary prevention, treatment for improving the quality of our life. But at this moment, there are not study confirming that secondary prevention effect of the melatonin therapy is present. Second part of my presentation is are actually reproductive effects of melatonin, and that is something that I work mostly in my clinical practice. I will just show you how increasing number of the publication is concerning melatonin and polycystic ovary. And there is a reason for that, because after entering the bloodstream from the pineal gland, melatonin enters follicular fluid. It passes to the oocyte, and here you can see that with potent antioxidative properties, it reduces oxidative stress, it improves mitochondrial function, it reduces DNA damage, and finally improves the quality of the oocytes in the term of maturation, meiosis, and fertilization. This is one very nice cartoon showing us that actually intrafollicular fluid will determine which follicles will further grow and finish as an ovulation and future fertilization, and which one will not. They will remain small and remain a part of polycystic ovary syndrome. Therefore, it was expected that pre-treatment with melatonin will help our in vitro fertilization outcomes. And here is one of the meta-analysis showing us that pre-treatment with melatonin will significantly increase the number of the oocytes that will reach the stage of blastocysts. It will, at the same time, improve the quality of the embryos and improve the fertilization rate, especially in women who are poor responders. This is also a meta-analysis showing us that pre-treatment with melatonin in this group of women will improve the outcome of the IVF up to 40%. And I may say that this is true in the clinic where I work. We significantly improved the success with pre-treatment this woman with melatonin. If you want, and I just put this one slide here because an interesting title. Here you can see that melatonin improves oocyte and embryo qualities, but it will not improve the sleeping problems in women entering the IVF procedure. If you want if you want to further improve the effect of melatonin, you may add minoxidil, and this is the last slide in this part. I am showing. Here you can notice that in those women who had previously failure during IVF procedure, after 3 months of treatment, the 30% of them became pregnant. We have significantly less stimulation of the ovaries. There was a higher number of the high quality oocytes and embryos, and of course, increased fertilization rate. So I will finish my presentation with this slide. This can be a homework for young doctors. There are many studies in the recent years showing us that melatonin has potent anti-cancer effect, and not only primary anti-cancer, but effect on metastatic cancer disease, especially, for example, breast cancer. Thank you very much.
Thank you very much, Goran, for the excellent overview on something that is not so new, but new for us that are not following this regularly. So these are really a very nice inputs for the different aspects of metabolism and reproduction. And now we should continue with the reproduction, and it is really my great pleasure to introduce you my very great friend and collaborator in many studies in the recent and past period as well, which is Sarantis Livadas. He is coming from Athens, so we are now going to Athens in Greece. And I would like to invite Sarantis to tell us something about the polycystic ovary syndrome and the risk to develop type 2 diabetes. Sarantis, the Zoom is yours.
Thank you very much for the presentation, and thank you very much for the opportunity to be here with you. The title of my lecture will be the risk of type 2 diabetes in women with PCOS, and I'm going to present our data. As we all know, PCOS is not a disease, it's a syndrome. That means that we don't have a specific reason for the syndrome, but different. Women with PCOS are presented with polygon ovulation, which means oligomenorrhea, hyperandrogenemia, which means high androgen levels or hirsutism or acne, and polycystic ovarian morphology on ultrasound. Depending on the criteria used, and unfortunately I think that experts have to continue to conclude to one type of criteria, not difference, The incidence of PCOS ranges from 6% to 25% of women of reproductive age. As you understand from that, this is a very common endocrinopathy and we have to do something about it. Which is the role of insulin in PCOS pathophysiology? As I have mentioned, PCOS is not a disease, so we have some cardinal manifestations, which is insulin resistance and hyperandrogenemia. Insulin resistance by reducing skeletal mass action, liver action, and adipose tissue action, we have high levels of glucose. On the second hand, it has an effect on pituitary gland secretion, leading to increased LH, which will increase androgen production. Furthermore, SHBG levels are lower, meaning to higher androgen levels in the circulation. In fact, despite in ovary, where insulin action is normal, so high insulin, high androgen production, all other tissues have impaired insulin actions. This means that we have insulin resistance in glucose-accepting tissues, such as liver, skeletal mass, and adipocytes. And this will lead, unfortunately, to dysglycemia. This is a short slide, but very interesting because it shows that the cardinal manifestations of PCOS, hyperandrogenemia and insulin resistance, have a vicious circle, a chicken egg situation. The one amplifies the other, so we have to take care of both of them when we treat women with PCOS. Therefore, several experts believe that since there are raw data suggesting and a robust amount of data that insulin resistance is frequent in women with PCOS, the development of type 2 diabetes is something that we cannot avoid. And in fact, older guidelines have shown that in young age you have menstrual disorders and hepatogenemia, but as time goes by, in older age, these women will have metabolic abnormalities and type 2 diabetes will be the predominant one. In fact, if we have to develop hyperglycemia, we need two prerequisites, insulin resistance and beta cell dysfunction in order to develop diabetes. There is definitely insulin resistance in PCOS. There are several studies with clamps, which is the most appropriate technique to use to measure insulin resistance, which have shown that in comparison to controls, these women are insulin resistant. However, if you look at the data more closely, you can see that lean controls were more insulin sensitive than lean PCOS, but lean PCOS have the same degree of insulin resistance as overweight controls. Therefore, obesity plays a role in exacerbating insulin resistance. And what about beta cell function? It is known that disposition index is the most accurate measure to assess beta cell function. And it is shown, especially in obese women with PCOS, that beta cell function is attenuated, which is less in lean PCOS. Therefore, the two prerequisites exist, beta cell dysfunction and insulin resistance, but in a different degree according to BMI. And this is very important because 25% of women with PCOS are obese, and only 5% of women with PCOS are normal weight. Therefore, obesity and PCOS may coexist, and this may make it difficult to distinguish between these two situations. When we analyzed the available data of prospective studies of the evolution to diabetes, the early data published 20 years, 2 decades ago, have shown in very obese women that there is a progression to diabetes. However, when more data are accumulated, it was shown that the progression to diabetes is not as significant as it's supposed to be. And Gabineri study, which showed the incidence of diabetes according to BMI, have shown that the progression to diabetes of obese is significant, but not in normal weight or in overweight women. More data are accumulating, showing that through years, the PCOS phenotype is improved. We have more regular cycles, less androgens, and not as significant insulin resistance and diabetes as expected. This very interesting study published this year have shown in a very large cohort of PCOS that the risk of diabetes is very high in obese women, less in overweight. They don't have data for normal weight women, but this risk is exacerbated in hyperandrogenic women. So if you are obese and have hyperandrogenemia, the risk of diabetes is much more significant than if you are normal weight or overweight with hyperandrogenemia, emphasizing the double role of androgens and insulin resistance in type 2 diabetes development. So what happened through years? Through years, we found that the cycle length is modified and the folic number, which is one of the cardinal manifestations of PCOS pathophysiology, is lower. Furthermore, and this is even more interesting, you can see that LH levels, which augment androgen production, are getting lower, and this is followed by less testosterone and androgen levels after the third decade of life. This fact means that through time in PCOS, hyperandrogenemia is improved, which is very important. This led us to carry this study in 1,305 PCOS, assessing the impact of age on insulin resistance. And we have shown that the older we get, there is an association between HOMA and BMI. This HOMA is a marker of insulin resistance. In the same pattern, free androgen index increases in parallel with HOMA, so hyperandrogenemia enforces insulin resistance and vice versa. But what happened when we analyzed this data according to BMI? We have shown that through time, in overweight women, insulin resistance stays stable, but in overweight and in normal weight women, even in this, there is a substantial decrease, significant, in insulin resistance. If we see this data as a whole, we can see that obese women do not have an improvement in insulin resistance through time, but other normal weight or overweight women have shown a significant improvement. So one of the two prerequisites for type 2 diabetes development is improved in lean women with PCOS. And this is a further study we carry out in selected PCOS women, showing that androgen levels are significantly decreasing through age, and they are similar to controls. And this is associated with an improvement in insulin resistance in PCOS. This is only women with BMI 20 to 25. There are lean women with PCOS. So in these women, we don't accept metabolic abnormalities through time. So when this paper came out showing that the increase of diabetes is very high, 3.6 in a large cohort from women in Denmark, this was very peculiar. And when we asked the authors what happened about especially the woman with normal weight, it was found that diabetes risk was comparable to controls. Therefore, because overweight and obese women dominate PCOS population, we think that all PCOS are the risk of diabetes, not if they are lean and normal weight. All this data led us to carry this meta-analysis published this year in Endocrine, analyzing the risk of type 2 diabetes in all PCOS. And it's obvious that if you have PCOS, you have higher risk to develop diabetes. But what happens when you are obese PCOS? The risk is higher than 3.85. What happens when you are obese PCOS with obese controls? The risk is higher. But what happens when you are not obese PCOS, meaning BMI less than 30, comparing to this to the same piece? Then the risk is minimal, and we don't wait these women to develop diabetes through time. This data were further enforced by a very recent meta-analysis assessing from very large cohorts what happens about PCOS, diabetes, and cardiometabolic defects. And what the authors have found, that increased BMI, increased testosterone levels, low HCG levels, factors that are usually found in PCOS are directly linked with diabetes development, but they are directly linked with PCOS development, but data supporting that PCOS per se links to other diabetes or cardiometabolic events are not substantial. Therefore, maybe PCOS is not written by standard if you are lean, or maybe we don't have enough data to say that every woman with PCOS will develop diabetes. And this is a very interesting study by the Knife Group explaining the situation probably because it says that there are two different metabolic phenotypes, different genetic phenotypes in PCOS, the one which leads to metabolic abnormalities and the other one which leads to reproductive abnormalities. And in this group, the reproductive, SHBG and the LH are different, whether in metabolic group, higher BMI, higher insulin, less different glucose levels are modified. Then we can expect that if a patient has this type of cluster of genes, may develop metabolic PCOS, diabetic PCOS, on the other hand, will develop reproductive phenotype of PCOS. So what we have to do? And most of the problems in life come because there are two reasons. We act without thinking, every PCOS that has diabetes, or on the other hand, we keep thinking without acting. Let's do nothing, PCOS is very common. What we have found? We have found that metabolic gene clusters, obesity, hyperandrogenemia, sedentary lifestyle, age, endocrine disruptors, which should not be neglected, sleep disturbances, as my friend Gaurav has shown through melatonin, probably a family history of diabetes, mood disorders, long-term of OCPs, autocontraceptives, and maybe a role with vitamin D, maybe, or definitely, there are question marks on those, maybe, increase type 2 diabetes emergence. On the other hand, if you have a more favorable phenotype, if you lose weight, if you lose weight without being older, you have regular exercise, a healthy diet, you expect that the hyperandrogenemia will decrease, probably a role for drugs, then the risk of type 2 diabetes is improved. You can notice that age may be a plus or a minus in type 2 diabetes development. And it's important to have a minor loss weight. Weight loss by 5% will improve all aspects of type 2 diabetes development, liver insulin sensitivity, beta cell function, and skeletal muscle sensitivity, and will attenuate or regress the type 2 diabetes development. And we have a higher weight loss, then we have a complete modification of adipose tissue pathophysiology. Therefore, we have to aim these patients to lose weight. In conclusion, PCOS is the most common endocrinopathy in women of reproductive age, and the two cardinal manifestations of type 2 development, insulin resistance and beta cell dysfunction, they coexist. There is no doubt that the incidence of type 2 diabetes is higher in PCOS in cross-sectional studies compared to the APs. However, and this is the big modification, prospective studies have shown that the risk of type 2 diabetes is reduced in women of normal weight, but is increased in obese. And we suggest that probably this phenomenon should be explained by the decrease of androgen, which is something that happens in every PCOS woman through years. Therefore, we have to make efforts to prevent cardiometabolic complications in women with high risk and not in every woman with PCOS. And we think that obese women and women with positive family history are at the higher risk. What do we suggest? Of course, regular exercise, because regular exercise in every day will attenuate insulin resistance. Dietary advice, intermittent fasting because they have hyperglycemia is not advised. On the other hand, we want regular meals and avoidance of AGEs. These are glucotoxins digested through food. We think this is very important. Sleep is also very important because the worse sleep, as Goran showed, the worse metabolic. And the administration of metformin, liraglutide, and other dose, and the combination of glucagon and naltrexone may prove beneficial in order to maintain the weight loss. Thank you very much for your, thank you very much.
Thank you, Sarantis. Thank you, Sarantis, for this excellent presentation. There was so confusing details. I'm trying to find the answers that you made so clear during your presentation about development of type 2 diabetes in women with PCOS. Now we have the last presentation, and I'm very glad to represent the best possible representative of the Portuguese endocrinology at the moment, José Silva Nunes. As much as I know, his PhD was about metabolic surgery, and he has so many facts to report us. So, José, the Zoom is yours. Please deliver the presentation.
So, hello, good afternoon. First of all, I must thank to the organizing committee of this Congress through my good friend Goran Cvizovic. So I'm speaking about metabolic surgery. Is it just about insulin resistance control? That is a question that I try to answer throughout my presentation. So first of all, we are all aware of the ominous octet of Ralph de Fronzo explaining why type 2 diabetes appears. There are several factors, but insulin resistance is a core defect inducing decreased glucose uptake by muscle, increased lipolysis by the adipose tissue, and also an increased hepatic glucose production. What concerns lipolysis, we are all aware of the effect of insulin in adipose tissue, suppressing lipolysis and inducing lipogenesis. But if insulin resistance appears, there's dysfunction in terms of the adipose cells that become resistant to insulin's anti-lipolytic effect, and an increase in free fatty acid concentration that leads to lipotoxicity and the stimulation of gluconeogenesis. There is also an over concentration, that over concentration of free fatty acids induce ectopic lipid deposition in muscle, in liver, everywhere, inducing this metabolic disease. There is also a decreased glucose uptake by the periphery, essentially by the muscle, and we all know that insulin induces protein synthesis as well as glycogen synthesis. But if insulin resistance develops, there is an increased mobilization of free fatty acids, and that increase induces also an increase in terms of free fatty acid oxidation and reduction in terms of glucose utilization by the muscle. Concerning the liver, there is insulin at the level of the liver is responsible for suppressing gluconeogenesis as well as glycogenolysis, and in order to suppress the hepatic glucose uptake. But when insulin resistance develops, there is an increase, a small increase in glycogenolysis and a big increase in gluconeogenesis, increasing the overall hepatic glucose production. So we, at the present time, we face a pandemic of obesity, and we all know that obesity is a driver for insulin resistance, because with an increase in the adipose tissue, there is a change in the hormone profile, because we are all aware that adipose tissue is an endocrine organ, and there is a decrease in the beneficial hormone adiponectin, and an increase in all those insulin-resistant involved hormones, as well as an increase in pro-inflammatory cytokines. There is also a shift from the M2 anti-inflammatory macrophages into M1 pro-inflammatory macrophages, because adipose tissue is not only adipocytes. There's a big number of macrophages, essentially when there is an overwhelming development of adipose tissue, essentially in intra-abdominal location. And there is also the influence of gut microbiota, changing the energy metabolism, inducing a greater permeability of the gut wall, an overall insulin resistance, and also a change in the bile acid metabolism. And then came bariatric surgery. Bariatric surgery, as far as I know, the term bariatric came from the Greek word baros, but there is a Greek person here that can comment on that. And baros, at least as I know, means heavy weight. So bariatric surgery was a surgery that was developed in order to control severe obesity. What are the common bariatric procedures? The gastric band, adjustable gastric band that creates a pouch in the stomach, and that does not allow persons to eat a lot of food. There is also the sleeve gastrectomy that transforms the stomach into a sleeve as a continuation of the esophagus. There is the classic gastric bypass, Roux-en-Y gastric bypass, that bypassed the initial portion of the duodenum, so the food cannot be absorbed there. And there is the biliopancreatic diversion, that is a big bypass, a larger portion of the intestine that is excluded from the absorption. And there is a new technique, not so new, but it is evolving, and in our center, it is the most common procedure that we use. It's one anastomosis gastric bypass, because it is consisted of one anastomosis instead of two anastomoses as the classic Roux-en-Y gastric bypass. Bariatric surgery is clinically effective for severe obese people, and is also cost effective in terms of what we can save in terms of all the diseases related to obesity. Here I present the criteria for bariatric surgery in our center. All the patients with a BMI over 40 or over 35 if some comorbidities are present. But in what respect to type 2 diabetes, we are more liberal. We consider a BMI over 30 if an optimal metabolic control could not be achieved. For the proper treatment of those patients, we need a multidisciplinary team, because if we do not do in a multidisciplinary way, things can go wrong, very wrong. So this is our team. Some years ago, Buchwald presented a systematic review of bariatric surgery, and he showed that one particular condition, that is type 2 diabetes, could be remitted or resolved in 48% of people submitted to adjustable gastric band, or in 84% of with gastric bypass, and almost 100% with biliopancreatic diversion. So a very provocative editorial appeared by Francesco Rubino, that is a surgeon dedicated to the treatment of diabetes, of type 2 diabetes. And he questioned if type 2 diabetes could be an operable intestinal disease. So with that, we move from bariatric surgery into metabolic surgery. That is a surgery not to treat severe obesity, but to treat type 2 diabetes. I present some data from the Swedish obese subject study, SOS, and with 20 years follow-up, showing that the gastric bypass is the best technique in terms of losing weight. But we have also data from US, from the Stampede group, showing and comparing gastric bypass, the classic gastric bypass, Roux-en-Y gastric bypass with sleeve gastrectomy, showing that in terms of body mass index, the greater reduction was achieved with gastric bypass. But not only a reduction in BMI, also a reduction in HbA1c, and concerning the resolution or the remission of type 2 diabetes, it could be achieved in 45% of patients in a period of 5 years with gastric bypass, and in 25% of patients in a 5-year period with sleeve gastrectomy. But this year were presented the results from an European group led by Geltrude Mingroni from Italy, showing and comparing gastric bypass with biliopancreatic diversion, the benefits in terms of weight loss and also in terms of metabolic control. All those patients were diabetic, type 2 diabetic patients. In what is related to type 2 diabetes resolution with gastric bypass, all the patients need no anti-diabetic medication by the year 2. 79% needed no medication by year 5, and only 25% need no medication by year 10. Greater improvement in with biliopancreatic diversion we can discuss in some minutes, but biliopancreatic diversion is a technique that we do not perform here in our center, because we create a disease to treat other diseases, because the malnutrition is so severe that the benefits are very low. So how metabolic surgery fully work? We don't know. Nobody knows, but we know some aspects of that effect. we know that there is an improvement in insulin resistance. There are several hormonal changes. There's an alterations in terms of the profile of the cytokines, hepatokines, and myokines after surgery. There's also an altered immune functions in terms of beneficial alteration, and changes in bile acids, and a change in terms of gut microbiota. After bariatric surgery, there's a great increase in terms of hepatic insulin sensitivity. There's several alterations, changes in terms of hormones, and it depends on the procedures. Some procedures induce greater hormonal changes than others. The weight loss that we see after bariatric surgery decreases insulin resistance as a whole, and that leads to a greater metabolic or a better metabolic control, even inducing remission of type 2 diabetes, remission of metabolic syndromes, of the metabolic syndrome, improvement in inflammation, altered lipid profile, and improvement in terms of sleep apnea. And ultimately, it induced a reduction in cardiovascular risk, a regression in the atherosclerotic process, an improvement in terms of complications of diabetes and also of obesity complications, and the regeneration of the fiber, the nerve fibers. There is a paper published 12 years or 11 years ago, done in Brazil, that assess the effect of gastric bypass on the whole body insulin sensitivity. And it showed that there was no direct effect in terms of peripheral insulin sensitivity, although there was a big decrease in terms of BMI. In terms of hormones, after bariatric surgery, we can see a big decrease in terms of ghrelin, and ghrelin is the hormone of the hunger. And with both techniques, sleeve gastrectomy and gastric bypass, we see a decrease. In Roux-en-Y gastric bypass, the decrease is not always seen, and there is a variation through time after bariatric surgery. But we do see a decrease in terms of leptin, an increase in terms of GLP-1, and also in adiponectin levels. And I must remember that adiponectin has a beneficial effect in terms of the atherosclerotic process, and also inducing higher insulin sensitivity. But there is also changes in terms of the adipokines, with an increase in adiponectin, a decrease in leptin, and several pro-inflammatory cytokines, an increase in irisin, that is a precious myokine, and also a decrease in terms of FGF21 produced by the muscle. In terms of the liver, there is mainly an increase in IGF-BP2 and a decrease in FGF21. There is also a reverse polarization of macrophages, decreasing the amount of M1 pro-inflammatory macrophages, and an increase in M2 anti-inflammatory macrophages. In terms of bile acids, there is also a change, and they act in several organs, mainly through FXR receptor and also TGR5 receptor, inducing several beneficial effects. And finally, there is a change in gut microbiota, not only a decrease in terms of Firmicutes species, but also a greater diversity of bacteria. And we know that as long as we have a big diversity, that is very good in terms of metabolism. So with bariatric and metabolic surgery, what we know at the present days, we know that obesity associates with a chronic low-grade inflammation, that obesity is a major or the big risk factor for type 2 diabetes. Insulin resistance is one of the most important etiological factors for type 2 diabetes, but not the only one. That gastrointestinal surgery is the most effective treatment for severe obesity, not only for obesity, but also for the obesity comorbidities. That gastrointestinal surgery can reverse the pro-inflammatory profile associated with obesity and diabetes, and the mechanism involves a very complex dialogue between the endocrine system, the immune system, the bile acids, and also all the systems of cytokines. And that the bariatric gut microbiota is a no evolving promise, and there are several studies trying to change the gut microbiota, and also studies with the fecal transplantation done essentially by a Dutch group. So concerning my first question, is metabolic surgery just about insulin resistance control? It is not. So I must thank for your attention, and spasibo za vaše vнимание.
Thank you, Jose, very much. This was an exciting road through the metabolic from the beginning to the end with the surgical interventions. And I'm really also very fond of calling this the metabolic surgery. So thank you very much. And we have only 7 minutes more, and we have some questions here on the side. So I would like just to select a few of them, and I will start with myself. There is a question from the audience that is said, is it possible to prognose gestational diabetes before pregnancy? So this is a general question that we try to answer through this symposium, I believe, Sarantis and myself, but also Goran touched a little bit. So if we know the patient, if we know the profile of the patient and probably the family history of the patient, and if we see the patient, we can say, okay, this patient is prone to develop, especially if it is belonging to one of the groups like the Polycystic ovarian syndrome. So those girls and the young mothers will be with a more pronounced possibility to have the gestational diabetes with them. So we have a plethora of factors with starting from the obesity to some hormonal derangements like the PCOS, and probably some other things through the life. But the other question is there any genetic markers? I couldn't say that there are strict and very defined genetic markers, because this is really the polygenic situation, and today we are talking about the polygenic diseases. So I believe that there are no exact genetic markers. I believe that Sarantis can comment on this also, and to ask him another question that came to his side about the what is the is there any data about the intermittent fasting effectiveness in the patients with polycystic ovarian syndrome and insulin resistance? So we are coming to the obesity plus insulin resistance and going in different directions. So Sarantis, can you just briefly answer?
PCOS has an ever-changing phenotype, and insulin resistant if you are starving, and after 3-4 hours of starving, you want to eat something. Otherwise, you eat something sweet in order to feel better. Therefore, intermittent fasting is not advised, although there are no data suggested in favor or not. But from a practical practice, when these women, they eat late at night, they feel better than when they eat early at night and then they are starving for the rest of the day. Regarding genes, all these studies I have shown there are PCOS is a polygenic trait, and these are studies of SNPs, and we have a very high P-21 in order to have significant, and we don't have a several gene in order to say this is good or bad. Probably they will develop clusters of genes through microarrays, and then we have some genotype tools, such as in breast cancer, in order to find out which woman will be more prone to develop metabolic abnormalities. Thank you.
Yeah, thank you very much. So concerning the dietary intervention, I believe that we have to apply the non-pharmacological strategy to them generally. So I think that we have to address more precisely, and this is the area of great interest because there are no definitions on the training or the specific dietary regimen. So I think that this is also really important. One question is for Goran. It is related to how the melatonin is applicable to the patients, and what is the suggestion from your side how the patients will select the formulation of melatonin? What will be the best dose for the melatonin? At what time and at what frequency they can use it? What can you say about the very practical things related to melatonin?
Yes, well, first of all, I would like to say that melatonin is very safe treatment. As you can notice from the studies, there are different doses that were used. For example, for a pre-treatment for IVF, we usually use 2 or 3 milligrams of melatonin. For metabolic effects, studies usually use treatments with 3 to 10 milligrams, but also there are studies with healthy volunteers and with patients with amyotrophic lateral sclerosis, where the patients were treated with even 50 or 100 or 300 milligrams. Usually melatonin is given before sleep. And I may say there were extremely rare patients who reported that they have absolutely oppositely from that what we expected. They had insomnia and they were malaise in the morning, or they have nightmares, but this is really extremely rare. And absolutely nothing that will, their general health will be at risk. So I may say every man can take or woman can take melatonin, even those with PCOS. It is even recommended for my point of view, especially to the Jose patients, because he done everything with surgery, and this is much more easier way. Of course, it does not have such a strong impact as bariatric surgery. So I also noticed some questions about Jose, and I would like to ask him, is there any contraindications for bariatric surgery, and is there any necessary treatment after bariatric surgery?
The bariatric surgery must be an option after failure of conventional therapy. But we have patients with weight over 200 or 300 kilos. So even with conventional treatment, we are not. We know previously that it won't work, but we can make the patient to lose 10 or 20 kilos, but he will be very severe obese. So first of all, for the not so severe obesity, try before a conventional approach. Then we must exclude psychopathology, because if it is not excluded, the risk of alcoholism after bariatric surgery is very high. Even with that psychological evaluation, lots of patients after bariatric surgery, they move from the addiction to food to addiction to alcohol. It is studied, and we can see that in our patients. We must also exclude addiction from narcotics. They must, first of all, they must treat that addiction and then return to be submitted to bariatric surgery. And the patient must be committed to a long-term follow-up. We, at the beginning, we do a follow-up of 10 years after bariatric surgery. Then we must decrease to 5 years. Now we do a follow-up of 3 years because we had a 5-time increase in terms of patients. We perform around 300 to 400 patients every year. With the exception of during the pandemic. So we do not have enough people to follow up all those patients. But what is established by the General Directorate of Health here in Portugal is a minimum of 3 years follow-up in our center and for the life with the GP of that patient. And the other thing, every patient submitted to bariatric surgery needs a high dose of mineral and vitamin supplementation for the life. If the patient cannot afford that supplementation, that it is not reimbursed, and here in Portugal is not very cheap, so he is not a good candidate for bariatric surgery. We reinforce every patient that they need to do that supplementation for the life, because if they do not, they develop very severe neuropathies and lots of diseases. And we see that with some patients that were submitted in to bariatric surgery in other countries, and for the expenses, they could not buy the supplementation, and then they immigrate to Portugal, and they were like old ladies and old gentlemen. The decrease in terms of calcium, of several vitamins, of not to mention the iron, that is the most common deficiency, if not fully compensated. It's essential to do that supplementation for the life.
Thank you.
Thank you very much, Jose. And we are a little bit short with time. And I would like to thank to all the speakers for this excellent, really, overview on what is new in the metabolic and reproductive endocrinology today. So thank you for being with us on the Endocrine Symposium of this year's Congress. And all the luck and all the best, and see you soon. Bye.
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 Thank you. Many thanks to everybody. I will back next week with my messages, with my mails. Now we should start the next session with Kazakh Republic. Bye bye.
Bye bye.
Bye bye. Так.
Good evening, distinguished colleagues. This is hall number 6, symposium organized by the Kazakh speakers, Cardiovascular Risk Management in Clinical Practice. I am the moderator of the symposium. I chair the Department of Internal Medicine of the Kazakh National University. Shulpan Bulatovna is the sole moderator of our symposium, and I would like to give the floor to Shulpan Bulatova, who will introduce the next speaker. I would like to welcome all the participants in the Congress. Thanks for joining in our symposium. Now I'd like to introduce the professor of the Department of Internal Medicine number 2, the Akhmanov West Kazakhstan University, Professor Zhaodin, who will be talking on the subject type 2 diabetes mellitus, cardiovascular risk management. Please. Please, Professor Zhaodin. Good evening, dear colleagues, esteemed members of the EAT. Thank you for the introduction. The subject of my presentation has already been mentioned. Today, we know that diabetes mellitus is a growing epidemic. In 2014, there were 387 million people with diabetes mellitus. By 2035, there will be a growth by 55%, and we have 592 million people with diabetes mellitus. Moreover, these are patients with diabetes mellitus type 2. Half of them do not know they have diabetes mellitus. It is also known that 2/3 of patients with diabetes mellitus die from cardiovascular complications, in particular ischemic heart disease, stroke, and peripheral vessel disease. These factors were published in 1999 by the American Association of Cardiologists. So diabetes mellitus is considered to be a cardiovascular disease. As a result of this prospective study, which included more than 800,000 people, it was established that only the presence of diabetes mellitus without accompanying cardiovascular diseases can reduce life expectancy of our patients by 6 years as compared to healthy individuals, so without diabetes mellitus. If we think about this fact, does diabetes mellitus have an impact on emergence of major cardiovascular complications? In English-speaking literature, such as death, myocardial infarction, and stroke, you can see that with diabetes mellitus, there is an increase in ischemic heart disease by a factor of 2, stroke by 2.4 times, other deaths, except for myocardial infarction, 1.7 times. So let's discuss this situation. Why does it happen? How it depends on the glycemic profile. If we control glycemia, if the indicator is less than 7 millimoles, the risk of cardiovascular complications is 1.6. If it's more than 7, 2.3 times. Let me also draw your attention to the fact that we need to have a strict glucose control, but even that does not reduce the risk of cardiovascular complications. Even if people without diabetes mellitus have the glucose level 5 to 6, there is a moderate risk of development of cardiovascular complications. If it's more than 7 micromoles per liter, then the risk increases by 1.7 times. This slide shows the major studies showing the risk of emergence of cardiovascular complications in patients with diabetes mellitus. The first study, UPBDS, is probably the most important one in endocrinology. That's the Bible of endocrinology. It showed that the higher the glucose level, the higher the mortality rate and heart failure levels. Well, if HbA1c was dropped by 0.9% from 7.9 to 7%, there was a significant reduction of all complications related to diabetes mellitus. The risk of reduction of myocardial infarction was borderline, but as for cardiovascular mortality, it hasn't changed. After this, there were studies aimed at achieving the lower HbA1c, and COMPASS study was one of them. And the lower glycemic level was accompanied by an increase by 28% of death. That was a failed study. When interrogators look at the risk of sudden heart death, it turned out that all sugar-lowering drugs can be divided into insulin providers and insulin sensitizers. This study showed that insulin providers, such as sulfonylurea drugs, increased the mortality rate by 27%, but insulin sensitizers, such as Metformin and gasolinidines, reduced by 35% the risk of sudden death. It became clear that glucose plays a certain role, but that's not the only factor. And if people live longer with diabetes mellitus type 2, plus they have accompanying diseases, the less the chance that strict glycemic control can prevent cardiovascular complications. Now let's see how we can bring this puzzle together. At the top, well, we should deal with insulin resistance and control glucosuria. On the right, you can see control of arterial pressure. At the bottom, control of cholesterol or low density LDH cholesterol. And if you look at the COMPASS study, that's the so-called rivaroxaban, and it's used as an anticoagulant. Well, also the duration of diabetes mellitus is one of the first manifestations, and you can see that it ranks second after the peripheral artery disease. In this cohort study, which included almost 2 million patients, showed that if a person has diabetes mellitus, well, there is the prevalence rate of heart death from 10 to 30%. But if there is heart failure, well, the prevalence rate of diabetes mellitus is 30%. And if we examine a particular person in 20 or 30% of cases, we can also see such problems as problems with glucose tolerance. A 5-year survival for patients with heart failure without diabetes mellitus was 46% and 37% in patients with diabetes mellitus. Here are the results of the REGARD study published recently. They were discussed at the Congress of the Association of Cardiologists. It proved that diabetes mellitus is the most frequent accompanying disease in hospitalized patients and increases the risk of development of heart failure in patients with diabetes mellitus in patients under 65. Here is another interesting fact. The risk of development of heart failure in case of diabetes mellitus does not depend on other risk factors. Look at this slide. If we discuss such a thing, if diabetes mellitus leads to the appearance of atherosclerotic diseases such as strokes, you can see that the presence of diabetes mellitus at any age does not have an impact on stroke. But if the glycemic control is poor, if the blood pressure is poorly controlled, if this person has renal insufficiency and doesn't have proper cholesterol control, and the person remains a smoker, the risk of stroke is much higher. As you can see it here, and you can see all these factors impacting the risk of stroke. This article by Sifirovic, published in the European Journal of Heart Failure, showed that if there is the preserved ejection fraction, or if there is low ejection fraction, the presence of diabetes mellitus increases the risk of death by a factor of 1.5 to 2 times. If we look at the sugar-lowering drugs on reduction of cardiovascular diseases, 3 classical drugs shown here, insulin, sulfonylurea, and metformin, reduce the glycemic level, but they can increase the body mass index and can lead to hypoglycemia. As for metformin, it reduces HbA1c in a lesser amount, but it reduces the body mass index. It doesn't have a big impact on blood pressure and doesn't cause hypoglycemia. Modern drugs such as DPP-4 inhibitor or GLP-1 agonist and SGLT2 have a positive impact and prevents cardiovascular complications. Going back to metformin, the meta-analysis of 2017 showed that metformin reduces the risk by 22%, the risk of death, and the risk of heart failure and hospitalizations is also reduced at a similar percentage. As for DPP-4 inhibitors, they did not reduce cardiovascular complications, and they do not prevent heart failure. Until 2015, there had been just 2 studies showing an increase of the risk of cardiovascular complications in case of diabetes mellitus. That's UKPDS and STANO2, when besides glycemic control, the blood pressure levels and lipid levels were strictly controlled. In 2015, MPAR-REG were published. Then Canvas declared TIMI, Credence, and DAPR-HF, and Imperial reduced. And there is The study, which I will mention later in my slides, it has just been published. Going back to how heart failure is impacted by SGLT2 inhibitors, this slide shows the cardiovascular safety of these drugs, empagliflozin, canadarp. Well, you can see the results are quite impressive. They reduce the risk of heart failure and hence hospitalizations. And here you can see the recent study, Imperial Preserved. The results were published and discussed at the European Cardiology Society Congress. This study was devoted to efficacy and safety of empagliflozin in patients with the preserved ejection fraction and heart failure. Well, functional class 2 to 5, you can see the primary endpoint. The peculiarity of this study is that as for the secondary endpoint was the item related to nephroprotection. You can see the primary endpoint, it dropped by 21%. We know that before this study, when there was heart failure with preserved ejection fraction, there wasn't a single study showing the improvement of the prognosis for such patients. Here you can see what number of patients should be treated to save one life, and TT number needed to treat 34 patients. And here is the slide showing that the drug is a nephroprotector. It slows down the reduction of the glomerular filtration rate. Empagliflozin is effective when we have patients with different types of heart failure with reduced ejection fraction, that's imperial reduced, with moderate ejection fraction, and imperial preserved, showed that the prognosis is much better for patients with reduced ejection fraction. As for new European guidelines on treating patients with heart failure, we can see a new algorithm, class 1A, that means using ARNI or AMP as SGLT2 inhibitors such as dapagliflozin and empagliflozin, quadruple therapy as we call it. And if we look at the section devoted to the treatment of diabetes mellitus, you can see that the number of drugs has been expanded. Canagliflozin, dapa, sotagliflozin are recommended for patients with diabetes mellitus type 2 who have the risk of development of cardiovascular events in order to reduce the number of hospitalizations for heart failure, MACE, and of course the end stage of renal insufficiency and the number of deaths due to cardiovascular reasons. As for heart failure, dapagliflozin, empagliflozin, and sotagliflozin are recommended with the recommendation class 1A. Well, your time is almost up. Well, I'm going to wrap this up. Let me just show you the last slide. Please. As for SGLT2 inhibitors, these are anti-diabetic drugs together with hypoglycemic effect. They have also pleiotropic effects, and SGLT2 can prevent heart failure, and SGLT2 has a nephroprotective effect in patients with diabetes mellitus. Thank you very much. Thank you very much, Professor Jaldin, for such a detailed presentation on diabetes mellitus, because, well, as for physicians, I know it's not so easy for them to figure out what to do. The paradigm of treatment is changing rapidly, and we can use different methods to manage patients with cardiovascular risks. So our goal is to inform doctors about new achievements in this field. Now, I'd like to give the floor to the professor of the Department of Internal Medicine, the Kazakh National University, Professor Sorry, I did not turn on the microphone. We cannot hear you. Professor of the Department of Internal Medicine, Ms. Jangelva, and she will be speaking on assessment and management of risk factors in patients with chronic heart diseases. Please do not overrun your time. Please do not speak longer than 15 minutes. Thank you very much, Ahmedjan Bigalievich. I would like to thank the organizers of the Eurasian Congress of Internal Medicine for the opportunity to speak here. And I'd like to say that as for the situation with the mortality rate in Kazakhstan, according to the National Statistics Bureau, over the last 5 years, we can say that the mortality rate has been more or less stable, 67, 65. But over the last half a year of this year, we can see an increase in the mortality rate by 18%. And this is happening not because of the respiratory diseases such as pneumonia or common cold or the flu. You can see 8 of 12%, but also due to primarily circulatory illnesses. There is even such a phenomenon or concept, excessive mortality. The pandemic causes mortality, not just from the coronavirus infection, but the pandemic leads to a higher mortality rate from other diseases, in particular from circulatory diseases, which rank first, such as hypertension, ischemic heart disease, and stroke. Just to see here, basically, there is an increase of the mortality rate by 18%. Why is it happening in Kazakhstan as well? According to the data from our country, as for the dispensary list of people, we have about 2 million people who are monitored on a regular basis. And you can see that as for the modernized program of medical checkups, which has been modernized and introduced from 2013, 1 million patients were involved. So the coverage rate with this checkup program was about 56% in the Republic. You can see all the regions here shown by different bars. Another indicator I'd like to draw your attention to is that there has been an increase in the number of EMT calls, not because of the pandemic and the coronavirus infection, but because of the acute coronary syndromes. That means that the risk management is not properly developed as a system as we wanted to see. At the level of EMT, emergency medical teams, our population is about 19 million. And according to statistics, well, there should be at least 5 million people who undergo regular medical checkups, while this figure is only 2 million. And here I would like to give you a typical case. A patient who was hospitalized at the cardiology center. Well, it was non-STEMI patient. The patient is 66 years old, and of course, the patient had acute coronary syndrome. The patient had repeat myocardial infarction. Well, you can see it's a non-STEMI patient. The patient was stented, and that was in 2017. And look here, well, basically, this patient has a history of his diseases shown here, including all the risk factors such as poor hereditary smoking. He has been a smoker since he was 17, well, weight gain at 32, and at 45, the person knew that he had the high cholesterol level, arterial hypertension since 49 years old. He said, well, I had the surges of blood pressure, but I did not take antihypertensive drugs. He had angina, and at 57, he was hospitalized with myocardial infarction. And CAG was done, and there was the stenting, and now the patient is working, but at 59, the patient was again hospitalized with unstable angina, and only after this hospitalization, the person was registered at the outpatient clinic, and 2 years passed, and now he's at 61. He was hospitalized to our clinic with repeat myocardial infarction. In fact, we have the cardiovascular continuum here from risk factors to repeat myocardial infarction. And just see here, most part of this continuum, well, the person was not monitored at all, and we can see there was no primary prevention, no secondary prevention. So in fact, there was no self-management as we pay attention to in our disease management programs. When we asked this person what drugs he had been taking for 2 years, and it turned out he was on atorvastatin 20 milligrams, enalapril 10 milligrams, bisoprolol 2.5 milligrams, and aspirin 100 milligrams. And over a 2-year period, the doses remained the same. So what was originally prescribed continued for 2 years, and I think this led to the repeat myocardial infarction. The patient began to feel himself bad over the last 3 months. Well, the patient had chest pain, increased pressure, and hence a second myocardial infarction. Well, we also looked at similar patients who were hospitalized at our cardiac center. We looked at what drugs they were on before they were hospitalized. It turned out that practically all patients with repeat myocardial infarction, well, you can see half of them, red bars, did not take in drugs they were supposed to take after myocardial infarction. And the most horrible situation is with statins. Only 20% of patients were on statins. That is why we have this kind of statistics. Almost 40% of patients who come to us usually have repeat myocardial infarction. Right now, this patient is in a severe condition. Body mass index is 31, saturation 96, edema up to 1/3 of the lower leg. Well, rales in the hearts, well, heart murmur is dull. Well, you can see heart rate is 90. Well, the pressure 160/95. CAG was performed, and here we found a multi-vessel disease of coronary arteries, and we recommended TABIG for this patient. At the same time, the patient had elevated troponin up to 14. Echo showed, well, the expansion of the heart cavities, echinacea, and well, you can see the reduction of the ejection fraction of the left ventricle down to 36%. So this is the typical case of chronic heart failure. At our center, when the patient is hospitalized, the blood pressure is being measured. We fill in this blank, this form, and on the basis of this examination, it was shown that the difference in arterial pressure did not exist. Yes, it was an elevated kind of pressure, 150 over 76, 149 over 78. On the left, tachycardia, well, the pulse pressure is elevated. That's an additional risk factor for cardiovascular complications. Well, brachial shoulder index, is shown here, and also you can see that the orthostatic hypotension test was done, and there was a reduction by blood pressure by 36 millimeter mercury. So here you can see that the sympathetic problem occurs. Well, you can see anemia, iron deficiency, common cholesterol was 6.1. So atorvastatin, he was on for 2 years in the dose of 20 milligrams. Did not work at all, and it was not supposed to work because the dose was very small for this patient. Of course, well, as for low density lipoproteins, well, it was just only 412, and you can see the uric acid was extremely elevated. Why did this happen? Because we have patients who trust doctors a lot, but we see them only in critical conditions when there was the process of decompensation. So when we administer drugs in small doses, we hope that at the primary healthcare level, doctors will titrate those doses because patients can spend 7 to 10 days in our hospital. We cannot increase ACEs inhibitors. Well, and 1 month after the patient is discharged, according to the clinical protocol, well, primary care physicians must determine the common cholesterol and other markers. So a primary care physician must know how to manage cardiovascular risks and achieve treatment targets. Well, this case of a 61-year-old patient showed that his healthy life years were reduced because the risk factors he had were not controlled. That's the first thing. Second, we have missed opportunities after screening when the patient had dyslipidemia, high cholesterol and tachycardia and arterial hypertension established. It was not controlled for 15 years, and now we can see chronic coronary syndrome, and no medical therapy was administered to this patient with ischemic heart disease. The patient hasn't participated in medical checkups, annual medical checkups, because, well, when we're talking about annual medical checkups, we're talking about control and achieving target values according to our clinical protocols. So when we have a patient like that, there is a big chance of repeat myocardial infarction, and this is what happened in this case. The management of the patient was very poor at the level of primary care, and the blue color shows what was supposed to take place in the primary healthcare system. The internist and the cardiologist, together with the multidisciplinary team, were supposed to have a stricter control of this patient. And I have already mentioned about the program of chronic diseases management. Starting from 2013, we have introduced this program, and the program is based on the Kaiser pyramid in accordance with the level of management of chronic diseases. The first level is the newly detected patients without complications. So we manage such chronic diseases, 70 to 80% of such patients learn how to do self-management. The second level, patients with the high risk of chronic diseases. Here, of course, the healthcare facility provides care for such patients, and that's why we need this program of disease management. And the third level, these are very complex patients. That's case management. That's 5% of patients. So they are being monitored by us. These are patients who should be hospitalized and should undergo regular medical checkups. And as for our program, I should say that the main aspect here is awareness and informing the population. We basically sign a social compact so that the patient would be responsible for his health together with the doctor, teaching patients how to do self-care and the joint care plan. That's why I said 5% are those patients who are level 3 if we look at the average statistical indicators. For example, one catchment area has 1,700 patients, and 15 to 20% of all patients, that's about 425 people, must be included into the program. But in fact, only 150 patients are included in each catchment area. Usually, these are patients of the third level when little can be done for this person. Only palliative care can be provided. It's difficult to do something to put a person on level 2. Well, what we can do in the situation when the person is on the second level, well, we examine patients. We have the special management for them. The patient and the doctor know what particular indicators should be achieved during treatment. Well, group examination, calling patients for follow-up, and self-management support. Of course, there is a multidisciplinary team, and the main role here is performed by paramedics, because usually a general practitioner has 3 medical nurses. So these medical nurses should be trained properly. Specialists on healthy lifestyles. The medical nurse must know how to counsel patients, call them, and identify those who need a quick examination. And of course, the major role of the doctor in the primary healthcare system is to detect blood pressure, high blood pressure early, dyslipidemia, to administer adequate combination anti-hypertension therapy, and there should be a patient-oriented approach in achieving targeted treatment indicators, because we need to stop this chain of deaths caused by vascular comorbidities. Here you can see the risk factors when target organs have been affected, when we have specific clinical conditions. The black squares show those patients who were hospitalized to our clinic too late, but they should have been hospitalized earlier. In this case, it's easier to do the risk management. And here you can see the pyramid again. Remember, the patient should be part of the multidisciplinary team on solidarity responsibility for the patient's health. So the self-management is the foundation of this pyramid. Participation in regular medical checkups, potassium control, blood pressure control, rhythm control, ischemia control when we administer optimal therapy, also control of concomitant pathologies, anemia, COPD, diabetic mellitus, and of course, there is a need to increase the number of patients whom we will refer to the planned CAG and CABG. In our country, such procedures are done as part of the emergency program. So the conclusions of my today's presentations are shown here. How can we manage cardiovascular risks? Of course, as for the problems that we have in our system, we are aware of them. That means untimely detection of cardiovascular risk factors at the primary health care level and the inefficient management of such patients. That means not following such clinical protocols. We have the population strategy aimed at promoting a healthy lifestyle, and we must first and foremost focus on long-term management of cardiovascular risks and to increase the number of planned interventions in this field. There is a need to introduce a new working model of medical checkups, so that the patient would be personally responsible for cardiovascular risks. In this case, we can have a planned reduction of cardiovascular deaths, especially now in our difficult conditions of the COVID-19 pandemic. It is important to have all the patients included in our system of regular medical checkups. And you can see here our slogan, do what you're supposed to do, and things that are supposed to happen will happen. Well, Leo Tolstoy said that, Thomas Mallory said that, like English knights, we must fight for the health of our patients, and we must manage cardiovascular risks. Right now, it's the fall, it's autumn, and I invite you to Almaty at this time in particular, because once we had the Eurasian Congress of Internal Medicine in Almaty, I would like to go back to the pre-COVID period. You can see our apples, taste them, come anytime. And here is another picture, our residents who graduated from our medical schools. I hope they will strengthen our medical checkup programs. Together or united, we'll be stronger. Thank you very much. Thank you. We are overrunning our time, so please do not exceed the time limit, because my presentation is the last one and I might have no time at all. Now I'd like to give the floor to the professor of the Department of Internal Medicine of the Kazakhstan Medical University, Professor Zakibekova. Please, the risk factors in patients with thrombosis, with arterial hypertension. Thank you very much. Thank you, dear Russian colleagues. Thank you, Ahmedjan. And the theme of my presentation is risk factors with patients with arterial hypertension. We do not see you, Vinera. Please turn your laptop so that we could see you better. Yes, now we could see you better. And I think that the previous speaker spoke about the risk factors in patients with hypertension. And you can see some other examples here according to the results of the studies. Vinera, we can see you very well. Just move your camera down. Now it's vice versa. Now it's much better. Okay, just to fix the camera. And Framingham study showed that only 9 risk factors such as alcohol, hypertension, dyslipidemia, diabetes mellitus, obesity, psychosocial factors account for more than 90% of all risks related to myocardial infarction. According to the data of prevalence rate of arterial pressure, you can see that in Kazakhstan, 50% of the population suffer from hypertension. And I should say that hypertension leads to severe cardiovascular complications such as stroke or myocardial infarction. Nevertheless, the implementation of the program on reduction of hypertension, we can see that despite these programs, there were some positive trends to reduce the number of deaths from such diseases by 6%. We're talking about arterial hypertension as the major risk factor and the predictor of stroke, infarction, decompensated heart failure. Nevertheless, as of today, we encountered such modern problems as diastolic heart failure, atrial fibrillation, AF, chronic kidney disease, dementia, and high cardiometabolic risk. In Kazakhstan, we can see specific risk factors which are reversible, and they contribute a lot to the development of mortality from cardiovascular diseases, both among men and women. It's a poor diet, and that, as a result of this, can lead to excessive BMI and other problems. You can see it's a vicious circle, and again, you can see it's like a mounting ball, and at one point there is an explosion, and there is death, or there are cardiovascular complications. Many studies have shown that the level of blood pressure is directly linked to cardiovascular risks. The higher the arterial blood pressure is, the higher the risk of different events. The meta-analysis is shown here. It was published in one of the European journals, and you can see that the higher the pressure is, the higher the level of risk is going to be. So you can see the association between diastolic pressure and cardiovascular risks. There is a direct correlation here. Here is the assessment of a 5-year risk of cardiovascular diseases using the multivariant model over a period of 4 years. And of course, we can see that there should be treatment of patients with arterial hypertension based on control of cardiovascular risk factors. The drugs that we administer should lead to such positive effects as protection of major organs and targets, and also have the pleiotropic effect. With the analysis of 5 major observational studies has shown that even a small reduction of systolic pressure leads to the reduction of risk of cardiovascular complications. I always tell doctors, even when the pressure is 170/100, if you reduce it to 165/95, you can see the deaths from coronary heart disease and stroke will be reduced significantly. Hypertensive therapy properly chosen reduces the risk of cardiovascular diseases regardless of other diseases. And you can see the achieving of target pressure is impossible without therapy. And these are the foundation of European recommendations of 2019. In the Russian Federation, the new protocols on managing patients with arterial hypertension were adopted, as well as in Kazakhstan. And here you can see the meta-analysis. More than 300 studies showed that if we administer major classes of drugs, combination therapy improved the reduction of arterial pressure. And right now we can say that combination therapy is the best option to reduce hypertension in 70% of patients. Well, so we can say that this therapy is very effective. And just to prove that we know the sprint study, it has been mentioned at different congresses. You can see the reduction in the number of MACE by 30% as a result of this therapy. As for patients with stroke and ischemic heart disease, well, again, you can see the administration of such drugs had a positive effect on the reduction of stroke and coronary heart disease. Thus, we can say that the reduction of artificial of pressure by 5 millimeters reduces the risk of cardiovascular complications. And of course, our major goal is to improve the quality of life of patients and to extend the patient's life. Sometimes the control is poor. There might be strokes or infarctions, and of course, that means the drug was wrong or the dose was wrong. We didn't pay attention to all risk factors, and you can also see that right now the problem that we encounter is very serious, and we need to deal with this issue of arterial hypertension. Of course, we can use such drugs as ARNT and calcium antagonists and diuretics. That's the golden standard of management of such patients. Beta blockers are used only in separate clinical situations. I'd like also to say that since we participated in large-scale international studies on the use of sartans on patients with arterial hypertension, we know that there are a lot of different randomized trials who showed that if in 2000 sartans were used to treat cough, right now they are basically the same as ACEs inhibitors, and the data of 2018 show the ranking of anti-hypertension drugs, to what extent these drugs were used in 2013 as compared to 2007, and you can see that the use of ARNI had a positive effect. This class of drugs also has the metabolic effect, because today we're talking about improving the situation with risk factors. And of course, as you see, these unique properties should be fully used. Well, there are gamma receptors which basically suppress inflammation and reduce insulin resistance. Sartans also have their niche, but I would like to say a few words about the drug shown here. In Karaganda, Almaty, and other countries, there was the study, and as you can see it here, that's the constant
64 centers, and you see 64 centers, 41 entity of the Russian Federation. These are baseline characteristics. The average age, classical portrait, 55 years, hypertension longer than 5 years. Initially, that was arterial hypertension stage 1 and stage 2. Then we started analyzing. There were lots of patients with metabolic syndrome, body mass index, which was increased, and that was obesity grade 1. And to majority of patients, we started treatment of azilsartan. We started it both for monotherapy, 70%, and also on combined treatment. So here are the results. By visit 4, in fact, more than 90% of the patients gave us positive response to treatment. That is stabilization of blood pressure and reaching target levels. Also, what is very important, if we speak about the correction of risk factors, so depending on BMI, and I refer your attention to that, overweight, obesity grade 1, so these patients gave very good adequate response to reach good blood pressure, and azilsartan appeared to be quite beneficial to the lipid profile. And when we administer the drugs, we always should assess all these nuances. And this is how the main conclusions from this study was the patients with arterial hypertension grade 1, 2, who are overweight or who have obesity, so the treatment of azilsartan effectively reduced blood pressure. It was really very good response of patients, especially patients with obesity, and it did not depend on BMI, presence or absence of diabetes, impaired glucose tolerance, etc. Also, it was reported improvement of the lipid spectrum, and meta-analysis of some randomized trials also confirmed all these beneficial effects. Actually, we confirmed the data that were previously obtained in meta-analysis, and the treatment of sartan, specifically azilsartan, influences very positively to the lipid profile of patients with arterial hypertension. And definitely, we cannot yet speak about fixed combination, because in 70% of cases we used 70% of fixed dose combination. And you see here there is a reduction of cardiovascular events, coronary events, atrial fibrillation, in more than 40% of cases. And the best protective effect from treatment, and the most important, that during 1 year, all the patients from monotherapy, they actually switch to the fixed dose combination, and this is how they reduce the hospitalization rate. We combine with thiazide-like diuretics and calcium antagonists, so we have the combination with chlortalidone, which was favorably influencing cardiovascular outcomes. All that is reflected in the international guidelines for the treatment of arterial hypertension, and in its high efficacy, we see the key reduction of both systolic and diastolic blood pressure and reaching target levels. So wrapping up, I would like to say that according to the recommendations, we know that if in 2007 there were no convincing evidence that the combined treatment is needed, is a must for the control of blood pressure in the majority of patients, then already in 2013, they started saying about the advantages of beginning of combined treatment, but nevertheless people were still quite cautious. But in 2018, we got evidence-based data on the reduction of cardiovascular events rate like strokes, MIs, congestive heart failure, and this is how we are already focused on the fixed dose combination in the management of patients with arterial hypertension. Thank you very much for your attention. And I try to press the time of my presentation because we are behind the schedule. Thank you very much. Thank you very much. And the final presentation will be mine. And I also wanted to introduce you, distinguished professor, and many thanks to Venera for very emotional presentation, very positive presentation. Because we all speak about risk factors, and we should properly treat arterial hypertension to save our patients from proper complications. Thank you. And now, let me introduce Professor Sugraliyev, who's the lead of chair of our university. He will present a very interesting data on the risk factors of venous thromboembolias, issues of primary and secondary prevention of venous thrombosis in the GP practice. Good afternoon, dear colleagues. On behalf of all the doctors, therapists, I would like to express gratitude to the organizers and also personally to Professor Arutyunov for this opportunity to speak up, to organize this Kazakhstan-based satellite symposium in the framework of Eurasian Forum. And definitely I would like to say that venous thrombosis is a very important topic. This is multifactorial disease, normally asymptomatic. We know that venous thrombosis only in 20% of the cases do have symptoms. Mainly it is reflected asymptomatic. Here you see lots of factors that potentially can influence venous thrombosis, and among them as it was mentioned before. There is heart failure, ischemic stroke, sedentary lifetime. In case of decompensation of heart failure, it could be bedridden patients. Of course, obesity, definitely COVID influenced a lot. So we should speak about infection as a risk factor. And also, I would like to emphasize the multifactorial influence and also D-dimer. D-dimer, as we know, is a marker of thrombus presence in organism, but there is more and more data about infections. So today we know that D-dimer confirms the presence of severity of inflammation in the vessels and, let's say, poor prognosis of the patients. Patients with different infectious diseases. Due to the fact that my time is very much limited, so initially I wanted to give 20 minutes to all the speakers and I booked 15 minutes for myself, but it appeared to be that we actually pressed all that, so I have very little time. But within this slide, I want to show you, distinguished colleagues, that when we have severe therapeutic patients, when he comes with decompensation, with the exacerbation of the severe diseases, and the patient is in a particular conditions, environment, and sometimes many patients, they need some interventions. You see surgery, hospitalization. So these risks are increasing. So it appears to be when we hospitalize the patient, we create particular So we create conditions for venous thromboembolic complications. And as patients are coming in the hospitals because of particular medical diseases, but currently venous thrombosis, group of patients with provoked thrombosis, so these patients belong to the risk of venous thrombosis during the acute event. So they belong to the category of high risk of thrombosis. Although if we analyze these patients for the thrombosis development in the long-term period, then these patients belong to the category of low risk. And these patients do not require long-term anticoagulant treatment. But we have a group of patients with unprovoked thrombosis, and their share is about 20%. So what are these patients? So these are patients where we do not identify particular risk factors. So this is a group of patients that belongs to the group of high risk for the development of the long-term relapse of venous thrombosis, and these patients definitely need long-term anticoagulant treatment. At the very beginning of my presentation, I already said that venous thrombosis are very multifactorial diseases with lots of risk factors. And on this slide, as I wanted to show you before to all the therapists about the patients who are coming with the decompensations of chronic heart failure. So this patient is intensive care unit. Specifically, you can appreciate that the condition of the patient is really severe. So there's some risk factors due to the condition of the patient. And this risk factor is decompensation of chronic heart failure, but at the same time, this condition led patient to the hospitalization. So patient is limited. So patient has venous catheters, and it adds on. And there is a condition related to the patients. And when a patient comes to the environment, it worsens the risks of thrombosis. So next thing, which is also very important. So all the patients who were hospitalized, and they are hospitalized, definitely they are discharged later on for the outpatient care. So they believe if patients there with acute therapeutic disease and the patient is in the hospital, as you can appreciate here, and at the same time we see that the risk of thrombosis in these patients in the hospital is just 10-26%. And the application of anticoagulants, specifically low molecular heparins for fondaparinux, for example, improves the risks of thrombosis for 50–60%. But although risk of thrombosis is ongoing since index events for about next 90 days, and it can be split into 3 periods. Period of being patient in the hospital, which is 10 to 26%, then period of discharge, so next 45 days, and the period which is left after 45 days. You can appreciate here, dear colleagues, in 60% of cases, 60, the risks of thrombosis. So thrombosis is developing immediately after the discharge from the hospital. And 80% of cases, thrombosis is developing within 45 days after index event. And just 4% of patients get prevention after the discharge. So what are these patients? What is the phenotype of these patients where we see the development of thrombosis? So these are patients with severe strokes, chronic heart failure, chronic obstructive pulmonary disease, and in these patients, we need to identify thrombosis risk and during the discharge. And what patients will have thrombosis risks after 45 days? So mainly, this is bedridden patients with severe So in what severe therapeutical diseases we have increased risk of venous thrombosis? So here are infections. This is really very relevant during COVID. Second is a heart failure, and the next one is stroke. But if you identify this is infection where we have respiratory failure, and in a number of patients we had heart failure, and definitely it's enough. It's enough, and it is very important to pay attention to that. If we appreciate the result of the clinical trials, so we do know that and this is Artemis with fondaparinux. So the using of these drugs, that means low molecular heparin and fondaparinux, really reduces the number of thrombosis. But at the same time, we need to pay attention due to the fact that we have now used anticoagulants wrongly. So we should pay attention to the risks of bleeds. And this is fondaparinux, which is much safer, much safer. So the importance of prevention in severe therapeutic patients is mentioned in multiple guidelines. The guidelines of the heart failure, and it is written there that all the patients that should indicate it, they should get prevention. But what is the reality? What is the reality in the world? Reality with prevention in the world. If you see the results of the ENDORSE study, and it shows that just only 50% of the patients are getting particular prevention, and it is different in different countries. And if we look at Kazakhstan, so we provide not enough prevention. So very recently, we had results of the Kazakh study in the Russian Journal of Arterial Thrombosis, and I want to tell you, so our data is one of the best hospitals in Kazakhstan. So we found out that we have very many patients with risk factors of venous thrombosis. And please appreciate what we do. So we have about 14% of the patients who had contraindications to the prevention, but they were getting prevention. And at the same time, there were patients who had contraindications, and there were some patients in 10% with no risk, but they were getting prevention. And if we appreciate it here, so what is the share of the patients that were getting real prevention according to the NCCP recommendation? So they were just 25%. like in all the countries. Maybe somewhere we are better or we are worse, but I would like to say that anyway, this is a really very important fact, and it is quite natural that what we do here, we should use existing recommendations, validated methods of the risk assessment, that is Caprini scale that allows to assess existing risk factors, the importance, and then it allows to select specific regimen of prevention and then to assess contraindications to this prevention. And due to the COVID, there are multiple scales. So they almost don't use dimer as a risk factor for venous thrombosis. So thrombosis, pulmonary artery thromboembolias, and what is the risk of relapse? So the more time, the higher the risk of thrombosis, and for that, we have different models, and in these models, distinguished colleagues, we actually use D-dimer as a marker of risk for the development of the secondary venous events. So I said it's not in primary. So this is also identified somewhere there, D-dimer and also dash score. It also should be taken into consideration then here too, also for the patients with D-dimer. But our symposium is called Management of Risk Factors. So we should not only identify the risks of thrombosis, but also risk related to the anticoagulant treatment, risks of bleeds. And for that, we have Orbi scale, Terry bleed, for example, Hasbled, and etc. And we need to say that, in fact, we are using definitely secondary prevention in a particular number of patients. If we look at the large clinical trials in the long-term period, so patients had, let's say, thrombosis, they should get 3 months obligatory treatment with anticoagulants. So the treatment is, we have this group of patients who need long-term prevention. So by now, long-term prevention, we use very low doses of some Peros anticoagulants. So rivaroxaban, apixaban, lower doses. And I have to say, for venous thromboembolia, and I want to say that in these studies, only 30%, almost 40% were the patients with thromboembolias of pulmonary arteries. And the vast majority of the patients, 60%, were patients with venous thrombosis. And the results of these studies, as I have to say, for the secondary prevention, very important, specifically for the prolonged prevention. And they use Peros anticoagulants, and this is very important. So these are NOACs, low doses of apixaban and rivaroxaban. And if the patient refuses from any anticoagulants, for example, then this patient can be recommended alternative, very close to anticoagulants, antithrombotic treatment using sulodexid and possibly acetyl salicylic acid. And definitely every time we need to inform them that this should be proper follow-up with anticoagulant treatment. We should always check tolerability, compliance, renal function, liver function, risks of bleeds. And now I would like to draw your attention to the following. Here are patients with antiphospholipid syndrome. So very many patients, they discharged from hospitals without test on antiphospholipid syndrome, and they're discharged on very fashionable NOACs. Then they come later, we see the tests, we check them, And we see patients with triple and dual antiphospholipid syndrome where the use of popular anticoagulants, they don't work. NOACs don't work there. And we should avoid it, dear colleagues, because these are very high risks. So if you have patient with venous thrombosis, please first assess the patient properly. You have to be confident that the patient does not have single, double, or triple antiphospholipid syndrome, and only then you can recommend NOACs. And at the end of my presentation, I would like to say that if we have patients with venous thrombosis, so normally we identify 3 phases of treatment. First, initial phase, where we initiate treatment of venous thrombosis, then maintenance in case of venous thrombosis, and minimal duration is 3 months, and then prolonged. And please appreciate here, the prolonged could be again for 3 category of patients with high risks of bleed, which is second here, and patients with low risks of bleed. And please appreciate here the doses of the recommended anticoagulants. So I think with that, as our time is a little bit pressed, I would like to finish, and I can read very important conclusions that I made. Yes, of course, because our time is until 5 p.m. Yes, dear colleagues, venous thrombosis, venous thromboembolism, in fact, is a multifactorial disease with lots of risk factors. And also, I would like to say that this disease, the risk of venous thrombosis, could be related with the main disease, for example, chronic heart failure, and also the fact that the patient is in specific conditions, specifically in the intensive treatment, intensive care unit. And plus to that, we have additional risk factors. So in patients with severe therapeutic diseases, we need to assess all the risks for the development of venous thrombosis, both at the moment of administration and at the moment of discharge. And I have to say that risk of venous thrombosis normally higher. So before the discharge and during the discharge. So please pay attention to that. And I have to say that the results of the international study indoors and our own studies show us that half of the hospitalized patients are getting adequate prevention. Also, I want to say that, yes, we are dealing with this issue. So we possibly have results a little bit better than in some other countries, or maybe worse versus other countries. But anyway, we want to admit that, yes, this challenge exists, which requires improvement or find proper solutions. And I want to call all the doctors who are listening to us. Don't use different scales. Both thrombotic events and also the bleeds. I want to say that patients with unprovoked thrombosis and also patients, oncology patients, they belong to the category of a very high risk, and they definitely require prolonged secondary prevention. So if needed, so if there is long-term anticoagulant treatment in patients, that means venous thrombosis, so if patient has no cancer or other tumor diseases, we should consider lower doses peros anticoagulants, specifically apixaban, 2.5 rivaroxaban. So that means after 6 months of using therapeutical doses. So this is a very, very important thing here. If patient refuses to take anticoagulants, and if patient is telling that I want to have very big physical exercise and I would be just falling down because of tension, but because when I want to say the use of anticoagulants, if the patient is traumatized, then frequently it leads to the development of the intramuscular hematomas. And I want to say that, yes, it's seen. If you give anticoagulants, if you give intramuscular injections, so there is a risk of this development. So here we can use sulodexide, acetylsalicylic acid for long-term prevention, because surrogate study showed us very good results for the prevention of the relapse. And I have to say that if the patient is getting pretty long-term anticoagulant treatment, I want to tell you that you should regularly assess what is the tolerability of treatment by the patients, how compliant the patient is to this recommended dose. And I want to say that very many patients, they simply skip. So recently one patient skipped and came with big thrombosis. So patient was discharged from the clinic using NOACs, although later on, after the examination, it appeared to be that patient has triple antiphospholipid syndrome. So that means liver function should be properly checked, because if the enzymes are higher than needed, so if this is a low risk of atrial fibrillation, that it creates high risk for the development of bleed. And dear colleagues, I would like to say that yesterday, for example, we had a patient who, let's say, was in the one clinic, and we examined, it appeared to be that we found thromboembolia, high-risk thromboembolia. And I want to say that devices, how we used pulse oximetry, oxygen saturation, and using heart rate, it almost didn't work. And then he listened, auscultated, so there was huge tachycardia, 130, but the machine is showing just 76 beats per minute, and saturation showing 96. And when we checked and rechecked, it appeared to be 80. So I would like to call all our colleagues, dear colleagues, sometimes portable devices show something different from the real picture. So please use auscultation, and you will definitely hear that. Listen to his or her heart, and it really shows you, because there was a pulse of 135. Saturation was, when we checked it, so saturation was 83%, and the blood pressure in the patient was also reducing. So that means high risk, and we provided reperfusion treatment to the patient. And in echocardiography, it had been seen the ratio of right ventricle to left ventricle. So that was, right ventricle was more than one. So it gives us a very high risk of close mortality. And today, this patient has been taken back, rehospitalized, and the ratio of right ventricle to left ventricle was 0.8. And patient looks happy, but actually patient is very much afraid what was behind that. So, dear colleagues, I would like to ask all of you, please pay attention to venous thrombosis, because in the previous part, we were mainly saying about ischemic heart disease, MI, strokes. But here I want to say that venous thrombosis is not less. There are more and more of them with COVID. Thank you very much. That's it from my side. And if we have some more minutes, we would be happy to answer the questions. So please use the chat function and provide your questions, comments, and remarks. Hopefully, we have about 10 minutes to answer these questions. Yes, we have first question in the chat. So the first question is: smoking of electronic cigarettes a risk factor for arterial hypertension? Venera, would you like to take this question? Yes. Just today, I have received an article about electronic cigarettes. For example, in the UK, so they recently finished a long-term study, which was carried out for 6 months under the auspice of the independent group of investigators, and it showed when there is a complete switch from cigarettes to the electronic cigarettes or tobacco heating, it can be compared to the complete quitting smoking cessation. But the study is ongoing. There is another digest here, an international journal on the emergency care. So they published a study that showed positive influence, let's say, versus continuation of the smoking. So it's better to switch to electronic cigarettes because their effect is let's say, much softer. So that's less toxic effect and less harm, both in terms of oncology or pulmonological diseases and also cardiovascular diseases. And also in that study, International Journal of Emergency Care, which was published quite recently, they show the results that the increase of HDL increase, and further studies with LDL still ongoing. So to avoid harm and better switch to electronic if people cannot quit. Yes, I would like to give a comment here. We just witnessed European Society of Cardiology Congress. It was carried out at the end of August this year. So they approved 4 different sets of guidelines, and one of them is for the prevention of cardiovascular diseases. So in these guidelines, they tell us that smoking is definitely a harm for the patients, especially patients with cardiovascular diseases. And as one of the steps to quit smoking, they need to switch to electronic cigarettes. So they recommend it. So electronic cigarette is not a replacement, Until hypertension, it would hardly help. But in order to quit smoking, as a bridging therapy, it could be option to quit smoking as one of the stages, because there are different materials in these cigarettes. So what filling materials, so how much nicotine is there? Definitely high nicotine, that would be really very harmful. No, but we don't have this evidence-based data. The study is still simply ongoing. The study is ongoing to study the electronic cigarettes to the influence human health. Now, second question here, which products? Oh, by the way, it has been said that if somebody smokes in the family, that means the whole family is smoking, because active smoking, when person smokes at home and brings, cloud of smoke with him, so his family members who do not smoke, they are passive smokers. So passive smoking is as dangerous as active one. So in that context, electronic cigarettes, well, if they are used, so there is less nicotine there, so at least it would be reduced level of passive smoking for the neighborhoods. Which products should be excluded from the nutrition for the prevention and development of arterial hypertension? Yet I think, first of all, salt things, because salt it's an enemy. So we should exclude salt, and plus to that, very fat animal fats, salt and animal fats. Yes, you should be focused on that, and then slowly and steadily you should switch to balanced nutrition. But mainly this is salt and trans fats. And also salt can be replaced by potassium-based salt. Well, at least some of it can be changed. So what about our time? Our time is coming to an end. Okay, question 3. What SGLT2 can be recommended to the patient with heart failure, with preserved ejection fraction, and with reduced ejection fraction in case of diabetes type 2? And also in presence of obesity? Would you mind the tactics of management? Who can take this question? I can try. Colleagues, this is the last question. Our time is over. In preserved function, in preserved ejection fraction, it is recommended empagliflozin, and this is very recent study. And depending on the obesity status, tactics will not be changed, because these drugs, they reduce body weight. Well, thank you very much. Dr. Zholdin, thank you very much. Well, colleagues, we cannot answer for the questions. Let's take another one. Self-control and self-management. Yes, we have legal acts to implement the program of disease management. Methodological Center is cardiology institution of the internal diseases. They control implementation of this format in all outpatient centers in the Republic. And there, the main important thing is self-management and self-control, because we manage the training of the nurses, of doctors, of HCPs, of residents on the program of patient management for this indication. That is management of chronic diseases. We have hypertension, we have heart failure, we have diabetes, and this year we added COPD. So we have 4 indications which are in our program. Thank you very much. So, distinguished colleagues, possibly it's high time to wrap up our session today. And I would like to thank all our speakers for very informative, for very elegant presentations. And also I would like to thank all our audience, all those who joined us today. So we do hope that we will see you later on. So once again, many thanks to the organizers of the Eurasian Association of Therapists Congress. And I would like to personally give many thanks to Professor Arutyunov and to the Secretary, Dr. Arutyunov, for the support, for the continuous efforts to involve Kazakhstan speakers, to the Eurasian Association of Therapists. Thank you very much. Have a good day and goodbye. And all of you, please proceed, please stay with us. Congress is huge. We have very busy agenda, and I'm pretty sure you will enjoy it later on. And the knowledge you gain today during the Congress will be very helpful and useful in your real practical work. Thank you very much. Have a good day and goodbye. Да.